Good morning, good afternoon, good evening, everyone. Thanks for joining yet another EPI-WIN webinar. And thanks particularly to those of you from places that are really late right now or really early. We really appreciate your participation. Welcome to the first of the series of webinars we're planning on mpox. So September, we will be focusing on the current mpox emergency. And we are kicking this off with today's webinar, which focuses on community protection. For those of you who are new to EPI-WIN, it aims to make science accessible, understandable, relevant for credible and evidence-informed action for both communities and decision makers. And today, we have a very exciting panel of speakers lined up. Our opening address will be given by Dr. Maria van Kerkhove, who is no stranger to you. She's also currently leading the mpox response in WHO. She will also give a strategic approach update. We then have Dr. Kai von Harbu, who's the unit head for community protection. He'll be talking about the community protection approach, along with Ombretta Maggio, who's senior advisor for community engagement and accountability at IFRC. So they will provide the more broader global perspective. Then we get the perspective from Africa with Dr. Susan Nyawade from WHO, Risk Communication Officer and WHO AFRO. And we will get a perspective from another region that's preparing for mpox with Dr. Ruben Mayorga, who's the lead for mpox and civil society engagement for communicable diseases in WHO PAHO. We also have with us, not speaking, but in the panel, Dr. Meg Doherty, who again is no stranger to you. She's the head of HIV/AIDS here at WHO, and many other eminent panelists right here. And at the end of the webinar, the closing remarks will be given by Dr. Nedrit Emiroglu. So I won't take up more of your time, but just quickly, housekeeping as usual, this is being recorded. It is being live streamed on YouTube. So you can see it again on YouTube later if you like. And the usual instructions, please introduce yourself on the chat. We'd love to know where you've come from and what you do, but please put your questions in the Q&A box, because if you put it on chat, we might miss it, and we really want to know what you have to ask us. So introduce yourself on chat, comments on chat, but questions in the Q&A box. And please put your comments, keep your comments constructive and positive. We're happy to hear from you and your suggestions, but please, it should be positive. Before I hand over to Maria, very quickly, we'd like 1 minute. We'd like to hear from you. So can you please tell us if you're working on mpox response for community protection or not? Join at slido.com, hashtag 3192598. We'll just give a few seconds here for you to, so that we know what you do. You can scan the QR code or join at slido.com, hashtag 3192598. So we have 100 respondents so far, a little more than 100. And it looks like about some of you are, most of you are not. So I hope you will learn from this webinar and find it useful. Thank you very much. And I now request Dr. Maria van Kerkhove to provide the opening remarks as well as a strategic update. Over to you, Maria.
Thanks, Apriya. So hi, everybody. Wonderful to see all of you again. And thank you for joining this EPI-WIN seminar. So very briefly, because you have a good panel and we want to leave plenty of time for Q&A. So I know you're following the mpox situation. I'm not going to present any slides here, but just to say there's a dynamic situation unfolding with regards to multiple outbreaks of mpox. Mainly in the Democratic Republic of the Congo, but also in some neighboring countries like Burundi, Kenya, Uganda. And this is largely due to Clade 1 and a new Clade, Clade 1b, that was first detected in September of 2023 and has been circulating for several months now. We at WHO are working with many partners around the world, especially with local partners on the ground through ministries of health and with support of the international community, many of you who are actually on the seminar itself, to address this challenge. First and foremost, to prevent infections of mpox, but also to stop the spread. We have published a strategic preparedness and response plan at a global level with the ultimate goal to stop these outbreaks. And through the work that we are doing with many partners around the world, we organize ourselves in different types of functional areas just to try to coordinate the different partners that are working and to have a strategic vision in support of different pillars of the response. One of those pillars is community protection, which you're going to talk about today. You've heard us say many times before, and you know this well, that communities are at the heart of emergencies. They are at the heart of equitable and effective responses to health emergencies, and communities have the power to prevent outbreaks from happening even in the first place. And so for us, when it comes to mpox, communities are not just a part of the solution. They're the heart of all of the different elements of what we want to do. So the strengths in any public health response lies in people, people who live and work within communities that are most affected. These are individuals who know their neighbors. These are individuals who understand the unique dynamics of their environment, and communities can quickly identify when something isn't right. Communities are often the first to notice unusual health patterns, making them essential for early detection, for quick action. Local leaders and civil society organizations who we are so grateful to work with are the ones who are trusted. They are the ones who can effectively communicate health information to overcome stigma or discrimination that might prevent people from seeking care. By involving communities, which is critical for us, we ensure that public health interventions are culturally relevant, that they are tailored to the specific needs for each population. This is why WHO puts community protection in its work with partners and networks that support and represent affected and vulnerable populations at the heart of our response. This is true for mpox, but this is true for any of the response activities, I would say prevention and response activities that WHO is involved in. And this is at the heart of our strategic preparedness and response plan at a global level. There's also a continental plan for Africa that is being developed, which will be published this week. And there as well, community protection is critical, community engagement is critical, community empowerment is critical. So the goal of the global SPRP is to stop and contain the mpox outbreaks of human-to-human transmission through coordinated global, regional, national, and subnational efforts. This can only be done when WHO, national governments, partners, and stakeholders join with civil society, community groups, and trusted networks that represent the voice of the communities that we serve. And I know there have been a number of EPI-WIN seminars that have focused on different communities, civil society. We've had many calls engaging different world of work, faith-based leaders, et cetera, to bring you into the response with us, to bring you in to be part of the solution. I currently am serving as the incident manager at the global level for mpox, but I work with incredible people here at WHO, in HQ, in our regions, in countries, and in partnerships across the UN with civil society, with local leaders as well, to implement this response plan. Our commitment to driving community protection outcomes for the most vulnerable and deserving is unwavering. Within our mandate of promoting health, keeping the world safe, and serving the vulnerable, WHO is committed to supporting processes that bring diverse voices and stakeholders together to share information, to discuss and learn from each other's experience and expertise. For community protection, this means working consistently with different partners and stakeholders, building local capacities, sustaining those local capacities, and ensuring communities have the information and the means to protect themselves and their loved ones during a crisis and to recover quickly. I think I will stop there because you have a number of excellent speakers, but I'm grateful for the EPI-WIN platform for having the opportunity to speak with you, and I wish you a very successful seminar. Back to you.
Thank you very much, Maria. Thanks for that overview, and thank you for your support, especially in engaging communities and reaching out to communities. I will now request Dr. Kai von Harbo to speak, but just before that, he will be talking about the community protection approach. But we'd like to hear from you first. What do you understand by community protection? Before we hear from Kai, we'd like to hear from all of you, the participants. Again, slido.com, hashtag 3192-598, or just scan the QR code. Okay, preparedness, surveillance, prevention, vaccination, risk education. These are some of the things that are coming up. Working together, participative and dynamic, herd immunity, community information. Right? Yes, it's indeed all of that. So thank you very much. We've had 169 responses, and you can continue to respond to that on Slido. But now we'd like to invite Kai to talk about the community protection approach. So over to you, Kai.
Yeah, thank you very much, Supriya, and thank you, Maria, for the great introduction and really framing this meeting very well. And as was mentioned already, this is the first in a series of EPI-WIN webinars on the mpox PHEIC, and of course today we will focus on community protection. Can we have the slides up, please? And my name is Dr. Kai von Harbo. I'm the unit head for community readiness and resilience in the country readiness strengthening department, which is led by Dr. Nedret Emiroglu, who is also online. And my unit is really leading on WHO's work around community protection as a subsystem of WHO's health emergency preparedness, prevention, response and resilience, or the HEPA framework. And we are now including community protection as one of the 5 pillars of the incident management system, along with collaborative surveillance, safe and scalable care, emergency coordination, and access to countermeasures. And this really, I think, represents a paradigm shift, both in the HEPA framework, as well as in our response coordination for this particular emergency, and really recognizes and underscores the critical role of communities and the importance of engaging at the community level and focusing on outcomes at the community level. And this, I think, has been a long-standing request to WHO to do more in this area, and we are addressing it with this approach. And this really, of course, we maintain and we have the technical approaches that we are all familiar with: risk communication, community engagement, infodemic management, etc., are at the center. But they are they are important for us to enable us to have a more focused and strategic and more impactful community-centered approach that puts also more emphasis on social and economic impact of health emergencies. And I speak about that in a little bit. And finally, just to acknowledge that this community protection cluster is co-led by me and Dr. Meg Doherty, Director for Global HIV, Hepatitis, and STI programs here at WHO. And she's also on the call. And And I really want to acknowledge the excellent collaboration over the past weeks with her and her team. Next slide. And just as ways of background, I think many of these were mentioned already. Next slide, please. Sorry, I think we, just to give a bit of the background, of course, on 13th of August, the emergency was declared a public health emergency of continental security by Africa CDC. And on 14th of August, a public health emergency of international concern by our WHO Director General on advice of the IHI Emergency Committee. And temporary recommendations were issued that put strong emphasis on enhancing community protection, including in particular risk communication and community engagement. And of course, these are in addition to the existing standing recommendations that equally have a strong emphasis on community protection. And then on 26th of August last week, a global strategic preparedness and response plan was published. And again, community protection is a core strategic area in this SPRP. And we describe key priority areas in the SPRP that we are implementing together with many partners, including many that are online today, and some of them will speak later, to really provide a comprehensive package for community protection. Next slide. And we have put together really what we recommend countries to implement to effectively prepare and respond to mpox under this new approach in an expanded package of interventions across these 11 domains that you are seeing here. And for each of these, we are working on specific advice and support tools that we are either updating or newly developing. And of course, risk communication, community engagement is the backbone of the community protection response. It's very important that we ensure and inform communities about protective behaviors because they are the key to end this outbreak. That's what we have learned in previous emergencies, including the previous mpox PHEIC. And of course, there's a lot of materials that we have developed already, but we have to make sure that these are culturally sensitive, that they are in the local language, and that they are relevant to the community's values and beliefs. So they need to be locally tailored. And this is what we are working on right now very closely across the 3 levels of WHO, down to the community level and with many, many partners. But we also need to move beyond messaging and one-way information. And that's where community engagement is so important, and that community feedback mechanisms are strengthened. And we need to ensure that the communities are sitting at the table in the decision-making process. And something that we have set up here at headquarters is a community advisory group with persons with lived experience of mpox to really inform the response and advise us on optimal community engagement, on optimal risk communication, on priorities and perspectives from the community. And we are developing similar guidance for similar participatory approaches in the decision-making at the national and subnational level that we will support countries with, because we think that's a key feature to address this response. And at the same time, it's really important to acknowledge the strengths and capacities that communities possess and their role as the first responder in every emergency. They are the first to pick up signals. They are the first to respond to them. And they are also the main avenue to deliver support and care to affected populations. And so we are putting a lot of emphasis on community-based care, home care, community-based surveillance as well, and also on strengthening community health workers as one very, very important aspect. Not only enabling community health workers to deliver those services to the communities they serve, but also to protect themselves, which is very, very important in many of these contexts. And again, we are working very closely, in particular with IFRC and UNICEF in these areas. And of course, we have a strong coordination platform with those 2 agencies, in particular in the collective service for RCCE. And we are expanding this partnership We just had the first partners call prior to this this webinar, which was co-convened with IFRC and UNICEF, but had a lot of other partners online to discuss how we coordinate and collaborate in this response. And of course, there's many other aspects to it, in particular following a One Health approach, so and an intersectoral coordination, and they're addressing those socioeconomic impacts, in particular on the highly vulnerable groups that are affected, like sex workers and children, and many others in these complex settings. This is an area that we put much more emphasis on in this response, and we again work very closely with colleagues on. Next slide. And what is I think an important lesson learned from previous emergencies is that no one agency can do this alone. We have to coordinate and collaborate with many partners, and we are doing this with these core partners that I mentioned already, but also with many civil society organizations. But this is really one of the key functions of this response, is really to ensure a coordinated approach. And there's some examples here of the mechanisms that we have set up in the past weeks, and we expand this further, in particular in this multi-sectoral space where also many partnerships exist, but that are not often yet so systematically set up. So this is something where we need to do more, and where you will hear more about in the coming weeks. Next slide. One slide back. Yeah, and this is, I think, the last slide. So just to highlight, and this is really a non-exhaustive list of all the guidance and products and tools that we are currently working on. Many of them have been updated already from the previous mpox to really adjust to the new context and the new Clade, the new transmission dynamics, the specific vulnerable groups, etc. Many of them are in the process of being updated and released. But we are providing they're disseminated across all our partners. So we have the collective service as a platform to share tools. We're also setting up an open WHO channel for capacity building, and a Hive community of practice. And I really encourage all of the partners to also share their tools with us and to disseminate those widely, because we really need to work together on those. And it's really important that we focus on adaptation and utilization at the field level. And this is, I think, it will be very relevant to hear from the regional colleagues as well. And where I look forward to a lot more conversation moving forward in this during this meeting. With this, I'm looking forward to the Q&A and many further discussions later on. This was just a very brief introduction. And I hand it back to you, Supriya.
Thank you very much, Kai. Thank you for elucidating so nicely, what the community approach is, what countries need to do, and how important it is. Now, I'd like to now invite Umbretta to give further perspective on that. Over to you, Umbretta. The floor is yours.
Thanks so much. Thanks, Kai, and thanks, Supriya, and thanks to the whole WHO team for having us in this webinar, but also for really launching this coordination system and the community protection pillar, which is bringing us all together for discussing our collective action. I'll share a few lessons that we've learned in the past year, something that can be useful for the preparedness, readiness, and response for this epidemic. And I'll start with my first slide, if you can get to the next one, that talks about behavioral drivers and trust. We've learned also through very hard lessons with attacks on our volunteers and on health services. We know that trust is at the center of our work in responding to epidemics. Behaviors drives epidemics, and the evidence is clear. Communities and their actions and the role they play in preventing and controlling epidemics. It is their actions that will bring an epidemic to an end. And no matter the tools that we have, the biomedical tools that we have, is going to be the people. The people will bring the epidemic to an end, be it an epidemic like Ebola or mpox or others, and we've seen during COVID. Trust is a key ingredient. If communities don't trust us, they won't listen to us, to our advice, to the information we share, no matter how much we do or how many channels of communication we have. So it's very important that we create this trusted relationship with communities by co-sharing the solutions, co-designing the solutions, and working together. Next slide, please. To do so, we really need to listen. And this is at the heart of what the Red Crescent has been doing over time in epidemics. If you can click through the 3 points, thank you. So at the heart of our work is really the community engagement and the risk communication approach that we take. And as I said, trust is at the center of what we do. To build trust, we need to listen and we need to act. And this entails really understanding the great insights, what people are thinking, believing, and saying around an epidemic. And this is true now, for example, around mpox. We've seen in DRC where we've responded at the beginning of the year and last year as well, how the number of questions have increased dramatically by 30 to 50% in terms of people asking for clarifications around different issues. And it's very important to understand what they think, what their anxieties and fears are. The other lesson that is coming from our community engagement work is that behavior change is a journey, is complex. Again, there are often cultural barriers and social norms. So no matter how beautiful our information is and how impactful it might be, women, children, men might decide for very different reasons that they don't want to access that service or go to the health facilities or vaccinate their children. So it's very important to understand, and this is the research and the tools we've developed collectively with UNICEF and WHO for doing this rapid research at the very beginning of epidemics. And then the last point is around community knows best. They do. They understand the dynamics in their communities. They understand who is the most trusted person or group in the community that can speak and will be heard in terms of taking preventive measures. So it's very important that we follow their leadership. Next one, please. Why are we not sleeping at night? All of us, why are we worried? And Maria said it clearly. We are faced with 3 different epidemics, different groups that are affected. And this is very important to know because this entails a very targeted and localized approach to these epidemics. And it can't be one simple message for all. So we have a new Clade. We have a new epidemic, which has many unknowns, is spreading through close contact, but not only sexual contacts. It has, we've heard this morning that 90% of the cases are driven by DRC. There is sustained community transmission in the east of Africa, is more severe, and there are many unknowns around the mode of transmission. This creates anxiety. We've seen over and over during COVID at the very beginning, it is important to have this open communication to say what we know, what we don't know. And we also are facing a challenge that we have limited availability of vaccines, testing, and treatment. And again, this creates fear, anxiety, and if I can go to the next slide, is fueling misinformation and fueling a number of confusion. There are concerns right now going on around, and these are some of the data that are coming out of Africa. I'm sure Susan will speak more about that. IRA, WHO, UNICEF social listening, but also the IFRC community feedback data. Concerns Again, reminiscence of COVID, concerns around public health and social measures, lockdowns, raising distrust on health authorities, what they say. There are conspiracy-driven fears and mistrust that is circulating, concerns around vaccines, and this we've seen over and over in the past and is coming out now again, something that is bringing back some fears and anxiety from the COVID time. There's a lot of information around how mpox is transmitted, the mode of transmission. There is less emphasis, less understanding people of the human transmission. So there is much more around animal to human, and it's important now to really re-emphasize this part. And again, stigmatizing attitudes that we've seen happening in 2022 against the LGBT communities, and I'm sure my colleagues will speak more around that. So moving to some of the considerations that we want to bring to the table, if you can go to the next slide. Yeah, next one. Yes. So these are some of the considerations that has come out of the work we've done since 2022, together with a number of other partners around community engagement data. Data is, of course, understanding the groups that are more affected at the moment, which are different from what we knew about this epidemic before. We see more children, more young adults, young youth, but understanding also, as I said, the community insights, what's coming out of these groups, what do they know, what do they believe? This is very important. Community-led actions, I think it's become very much a tagline, is part of our narrative, but what's behind that is really investing into supporting community systems, localized actions, community actors, which needs to happen before any epidemic, and in the readiness, preparedness, and long investment part. The third one is around framing this beyond only the sexual transmission. Many more people are infected now, as I said, children, young adults. It goes beyond the sexual transmission. It's important to change the narrative around that. Tailor community engagement. I said this before, a hyper-local approach is important to understand who is really infected. And in fact, I know WHO, AFRO, and CDC have joint efforts with many partners to be able to tailor this approach country by country and geographical area by geographical area. Discrete and targeted engagement with some of those groups that are more stigmatized than others, sexual workers, to the LGBTQ community, and this will require a different approach. So community engagement has to be tailored to different needs and engage and prepare the community health workforce. I want to spend 1 minute more on this. It's very important that the people that interact with those groups, with those communities, are well prepared. And we often forget this part. We often forget to really spend more time at the beginning of the epidemic to really ensure that people, that frontline workers, are comfortable with the questions and answers, that they know how to respond and engage communities. And my last point is continuously change continuously your approach, adapt, be agile, and be sure that you respond to a changing situation. People will change throughout an epidemic, and we need to change too. I'll stop here. My next slide has my contacts and the links I'm sure Supriya will share after the webinar. Thanks again, and over to Supriya.
Thank you very much, Umberta. Some very key considerations there. Very important when we talk about community protection. Thank you for addressing the importance of trust, especially in this emergency, where there's so many different aspects around about stigma, about the importance of data, and and all of that. And I just want to announce to everyone that we will share both the recording and most of the presentations with everyone after the webinar in the next week or so for all the attendees. So you will have access to the information. It's also live streamed on EPI-WIN YouTube, so you will have the information. Thank you for your questions. Also, I noticed a number of questions asking about mpox, how it's transmitted. Those are some questions that I think is on everyone's mind. So we've put the fact sheet and the information up on the chat for everyone to access. It will help you get some more information there. And I'm sure my colleagues will also be giving more specific answers to the Q&As, but we do have the fact sheet on the chat. But as Umbretta said, thank you for the overview. We now focus on Africa, and my colleague, Dr. Susan Nyawade. Over to you, Susan, to give us an idea about what is happening in communities in Africa in this very important and complex emergency. Over to you.
Thank you very much, Supriya, and thanks to those who have come before me. Is somebody putting up the slides on that side? Okay, thank you. So as you have heard, my name is Susan Nyawade. I'm a Risk Communication and Community Engagement Officer with the WHO Afro based in Nairobi. So I'll quickly take us through what is going on around the Afro region. After a very well put out background on what community protection is, and also specifically what community engagement is. Unfortunately, many times people hear RCCE and they only think communication and IEC materials, but there's much more. And we have learned that by engaging directly in a two-way communication at community level, we reach people better and we address their concerns as opposed to generic messages, because we have learned that it is not a one-size-fits-all sort of response. Next, please. So this is just to sort of lay the ground, and the previous speakers have already alluded to some of it. So when you get the slides, you can maybe look at it a little more. There was already reference to the fact that about 90% of the cases we are reporting in Africa are actually coming from DRC, and that the new ones, especially the countries that are reporting for the first time, that neighbor DRC and are mainly in East Africa, are reporting Clade 1B, which is known to be more transmissible and therefore affecting or is being transmitted from person to person, in which case the focus may not necessarily be on animal to person, but that doesn't rule that out. Just like Umbretta has mentioned, there's also been a focus on the transmission through sexual contact, which again has raised a lot of issues with a lot of misinformation. Whereas we want to ensure that those who are contracting it through that route need to take care of themselves. We don't want to reach a point where they are going to be stigmatized, because in some countries, this is, what they do is even illegal, which means that they may be targeted. Next, please. So I'll quickly look at some of the challenges that we have in the region. And the first one I've already alluded to, and others have alluded to. A few of the countries are reporting mpox for the very first time, whereas we also have countries in the region that have always had mpox, and therefore mpox is endemic in their countries. So given that there are so many countries, there are a number of countries, maybe not so many, but the numbers may go up, we don't know, that are reporting for the first time. There's an inadequate awareness, because many times people only move when this gets close to home. So it is important that we create awareness and ensure that people know what to look for, what do they do when they see signs and symptoms, etc. So generally, there's limited also understanding of behavioral factors that are driving transmission. And so beyond maybe the sexual contact, We of course know that close contact generally will, cause transmission, which may explain the reason why children are also contracting mpox. So at the moment, we don't have very many countries that have done this, and so that is going to be one of our focus. I've already alluded to stigma, just like Ombretta mentioned earlier, especially not just about the disease, but also the modes of transmission. Misinformation and infodemics is very rampant, and this especially together with the fact that the existing community feedback and infodemic management mechanisms do not have a lot around mpox, and therefore a code book is currently in the process of being put together to help in coding the messages that are being received, so that the interventions are targeted to the right groups of the population. And then there's also insufficient textualization of the response at the local level, so that even within a country, there are only certain areas that are reporting cases. And therefore, the response or even the interventions may not necessarily be applicable to the whole country. One may address the different areas differently. Just as an example of DRC, where we have 2 clades, and maybe clade 1B is more on the eastern part of the country. So the way we address them in different areas will depend on what the factors that are driving it are. Next, please. There's also insufficient integration with existing community networks. This is the backbone of community protection, as was alluded to by Kai earlier on, that there is need to work with those existing community networks, not just in the case, in this example of the people living with the HIV/AIDS, but others as well. So that this helps to create to reach key populations, like for example, the men who have sex with men, in the case where those are the main targets, or commercial sex workers, among others. And it also helps in contact tracing, so that we know where to find these people. And as I mentioned earlier, because of the stigma, we can only reach them through the existing groups that have already been working closely with them. The other big challenge in our area is that there are very many languages that are spoken in these countries, and there's need for translation, and I'm almost sure we don't have adequate capacity in terms of personnel and even finances, because it requires quite a bit of resources. So many of these countries have over 50 languages, and even though there's a national language and maybe an official language, there are areas within those countries where people do only speak the local language. And then the inadequate resources is a major challenge in terms of financial resources, as I've already alluded to, and also insufficient risk communication and community engagement workforce, or community protection workforce in this case, in terms of quantity, that is in numbers, as well as quality in terms of whether they are trained or not. And again, Ombretta alluded to training of community health workers, of course, along with the professionals who in turn train the community health workers. Next, please. So what are we currently doing, or what have we done? We have had bilateral deep dive with countries to understand their context and tailor the support. This is especially among countries that have reported cases, whether currently or in the past. Before that, we had a readiness survey for evidence generation, and this had targeted at-risk countries. These countries were those that were neighboring DRC and South Africa, who at the time were reporting cases. Then we are also sharing and facilitating understanding of tools, guidance, and materials. Most of these have been alluded to by Kai. Revision of plans, as again, Ombretta's last point was about updating, because this is dynamic. Things keep changing as we listen to the community, as we interact with them, then we learn new concerns, new questions that need to be addressed. There's need for capacity building on RCCE and also infodemic management with respect to mpox. And then updating information to countries. Again, this has been referenced by Kai. Real-time communication through the easiest communication channels, such as WhatsApp groups. And then we also have had deployment of personnel to both Burundi and South Africa through the GOAN as well as the collective service that again was referenced, especially in terms of collaboration and partnership. As mentioned earlier, this is work that one organization cannot do alone, and therefore we need to have more people. And this is why we are also capacitating and empowering communities to be able to take charge, because we know that when that is done, we are going to get buy-in, they'll own it, and for sustainability, it is more useful to do that than maybe somebody coming in to help and then leave and come back the next time. Next, please. So in terms of priority response actions, things that we are already doing, but we'll continue doing. So supporting countries to finalize their plans. Remember, new countries are reporting cases. Some had plans that were for readiness, but now as they report cases, they have to then add in activities that are for the response part, and also ensuring that these are translated into local languages as much as possible. Evidence generation is key. We need to listen to the community, and this again has been mentioned at length by Umbretta. So there's community feedback, and we also have behavioral studies which give us information that can help us to tailor the interventions that we have. Building capacity on mpox will continue as things evolve. This may be online sessions for national teams who then need to cascade. Supporting countries to contextualize the response in affected areas. As I mentioned earlier, there are different issues that need to be addressed in different areas, even within the same country. Then support countries with mapping of existing community structures. Again, this is one of the key activities and objectives of the community protection. Remember, we want to build capacity of those at community level, and we are not going to create new structures, but try and leverage on what is already existing so that, for continuity, and also people will tend to trust those they have worked with much more. And then supporting countries to co-design and implement effective community engagement for public awareness and especially for sustainability and resilience. Again, this has been mentioned before this. Next, please. And then finally, as I finish, some of these opportunities are available for supporting countries. And again, we are saying that this is being done collaboratively with different partners. So the existing networks and capacities that can be leveraged are available. Some have been used in the past for Ebola and also COVID-19, cholera, among others. And this could be CSOs, CBOs, and also groups such as the one that I had mentioned earlier that helps us to reach those suffering from HIV/AIDS. Capacity in anthropology and lessons learned. There's a lot, especially when rumors are going around. Some of this requires in-depth understanding, and so this needs to be built. It already was done in Ebola and also COVID-19 and even cholera, and so this can be leveraged. IRA, Africa Infodemic Response Alliance, again, was mentioned. This works very closely with the community feedback aspect, whereas they focus on the online feedback. We also have Red Cross and other partners who are collecting this data as they interact. Engaging partners to ensure that we can reach far and wide. We have an active risk communication and community engagement technical working group which is multi-agency. We have the collective service And we also still provide remote regional support to the countries in the region. I believe this should be my last slide. So I think the bottom line is that, as was mentioned earlier, emergencies start in the community and end there. And the community have some knowledge that they can actually, we can work on and improve on what is being done. Thank you very much, and back to you, Supriya.
Thank you very much, Susan, for that comprehensive presentation and for outlining, what needs to be done and what is being done currently. And obviously, there's a lot of work for all of us there. Now we go over to Ruben Mayorga, who's from PAHO, which is the Americas, for those of you who are not familiar with WHO regional acronyms. So he's going to tell us about how PAHO is preparing for the mpox emergency. Over to you, Ruben.
Thank you, Supriya. I'm delighted to be in this webinar. Actually, most of the presentation that I have is what we did with the outbreak of mpox from 2022 to 2023, and trying to explain a very different situation from the current one, but I think bringing us a lot of lessons for what we need to do ongoing. So how can I? Okay. So very, very soon upon acknowledging that the populations most affected by mpox during the outbreak in 2022-2023 were the same that we were servicing with programs for HIV prevention, treatment, and care, we started promoting joint meetings of these key populations with a group of National AIDS Program Directors in the Americas called Grupo de Cooperación Técnica Horizontal. We had meetings very, very early on, updating in each one of the thematic pillars, and many of them attended by several hundred participants, thanks to Zoom. We also had a forum in Lima in October of 2022 of several partners with more than 80 participants in the session around mpox. It was key populations together with national AIDS programs and other actors, and we had a declaration referring to the response to mpox in the region and having a lot of emphasis on vaccine access. We also provided assistance to civil society in Peru, together with UNAIDS and other agencies and the Ministry of Health's Communications Department, and we were able to promote the use of existing networks that were already very familiar with the National AIDS Program, doing additional services for mpox detection, and also with an added benefit of having for HIV being diagnosed and using all the community-based services for this. We published The Silence Can Be Damaging, with the objectives of giving knowledge about transmission, prevention, diagnosis, and treatment to encourage communities with bidirectional production of information, so back and forth, as Kai was mentioning earlier, and providing resources that facilitate dialogue among communities. And we had this first version. You will see in parts of the contents that we were really focusing on the community, talking about sexuality, because the outbreak in the Americas and the rest of the world in 22-23 was mainly through close sexual contact. So we spoke about the different things that needed to be spoken about regarding sexuality, and also social media and several sexual practices that were facilitating transmission of mpox. We also participated with the Euro and WHO office in Geneva, producing this survey with countries in Europe and the Americas, where we found out that a lot of gay men in the two regions did change their practices, thereby conferring them protection from infection, but that by May 2023, part of that behavioral change had already abated. We produced materials for civil society in Guatemala with validation of these products with the same population that were intended for, and they are now being adapted for regional communications around mpox for civil society in the Americas. We also had a memorandum of understanding between PAHO and Grindr, the app for sexual chat among gay men in the world, and it was intended to tackle misinformation on mpox and offer the populations valuable information on prevention, diagnosis, and care, and also setting the ground for further collaboration later on. These are some of the examples of what we have been doing with Grindr. And as a piece of information, we have between 1,000 and 1,500 consultations on the issues that you see here every day in the region. As part of the follow-up, we need to keep on producing risk communications material to promote differentiated services for key populations, continue integrating mpox into HIV and STI services, enhance screening for HIV and STIs among these key populations, that those gay men who were diagnosed late were the ones who died mainly in this region. We had about 80% of the fatalities during that outbreak. We also need to upscale PrEP and other combination prevention strategies, and we are starting to do that with Grindr, for example. And finally, promotion of joint elimination of diseases transmitted via sexual contact among these communities is one of our future steps in this response. I think that was my last slide, and here are the contacts at PAHO's HIV, STI, hepatitis, and tuberculosis unit that you can reach for any more information. Thank you.
Thank you very much, Ruben, for giving us an idea of how PAHO is preparing a number of toolkits and key issues to address people's concerns. Thank you for that overview. Now, we now have a great perspective from global to Afro-focused to a region that's not quite in an outbreak situation yet, but is preparing. So thank you to all the panelists. Now it's time to hear from the participants, the Q&A session. But just before we go to that, I've seen a number of questions regarding certificates. I'd like to just highlight to you that, first of all, I really hope all of you are here in EPI-WIN because you'd like to learn and enjoy and share your views on the topic. But we do give certificates, but EPI-WIN's aim is to provide something that's practically useful. So certificates are only given to those who complete the survey that you will get at the end of this webinar. And in the survey, you have to say that you want a certificate, first of all. And secondly, you have to describe to us how you will use the information from the webinar, clearly, because we want this to be useful to you. We don't just give certificates. But having said that, if you have done so, and you haven't received your certificates, because all of them, I think, except for the last webinar, have gone out, please write to us in epiwin@who.int. Tell us which specific webinar that you did not receive your certificate for, and we will check our list and follow up and get back to you. But I hope that you find the webinars useful with or without the certificates. But over to now the Q&A session. There've been a number of questions on a range of topics. So I'd just like to tell you that we are starting a series on mpox response on different topics. So in the following weeks, you will hear about clinical management, treatment, the EPI part and all the other issues. You will learn more about it. I've also shared the fact sheets, but for community protection, I'd first like to give the first question to Kai. It's from Rosvinder Singh, and he wants to know, how does the dynamics of the RCCE and participatory aspect come into play, especially when a large number of cases are from DRC that is also undergoing conflicts? How does the risk communication strategy change with the community when safety and security is a concern? Over to you, Kai.
Thank you very much, Supriya, and thank you for this very important question. I think we really have to acknowledge this kind of field level complexities, in particular when it comes to the security setting. It's an incredible, difficult setting to work in many ways, and of course the kind of insecurity is creating huge additional barriers to accessing healthcare services for the community. But also it's very important that we kind of put emphasis on the safety and security both of the community as well as the responders. So it's very important that we do systematic risk assessments and mitigation measures on how to best protect the responders. I know WHO has very strong mechanisms there, and all the partners as well. And it's very important that there's an interagency collaboration on this aspect as well. It's really important that that we look at a kind of alternate communication channels where needed, and that we really tailor the messages as well as the mechanisms to the local realities on the ground. And this is, you know, it's not easy to do and advise so much from here, from Geneva. It's very important that we work with the communities. We do in a participatory way. We find the trusted voices among the and leaders among the community and engage with them. And we really create localized messages that also address those fears and needs and the misinformation that is often even more prevalent in conflict settings. And some of the aspects that were mentioned already before, of course, is this trust building that is always important, but also in kind of fragile contexts in particular. So and then just to highlight that we put particular emphasis on the psychosocial support as well, both for communities and also for responders, especially when they're working and operating in such difficult settings. So that is something where we have to make a conscious effort and an investment in supporting the field teams working in these high-risk environments. That's in summary what I would advise. And if we have time, we could maybe ask Afro colleagues as well to share their experience in the specific setting. But I know we are a bit short in time, so I pass back to you, Supriya.
Thank you, Kai. I think very quickly, if we could hear from Susan as well, it would be great. Susan?
Hi, Supriya. Could you just please repeat the question? Sorry, I think I missed it.
The question is, you know, DRC is also undergoing conflicts, and there's the largest number of cases are in DRC. So how does risk communication strategy change with the community when safety and security is a concern?
Okay, in that case, and it is true that there's conflict in the DRC. It is also true that a good number of the cases are actually affecting people who are in IDPs, that is the displacement camps. So when it comes to risk communication, remember earlier I mentioned that a lot of times it depends on the context. And that is why it is important that we learn, we get to know what the context is. Who is it who can address these things? And when it comes to engaging, especially the community volunteers or people who are going to work in such areas, then it is important to build capacity of people who already belong to those entities, so that we are not going to have somebody moving in from elsewhere because it is not even possible to do so. So it's a question of identifying people within that community. Again, the word community can be used in very many different ways, but these are people living in an area where they are sharing a lot. So yes, in such areas that becomes a challenge. But again, this is why it is important to build capacity in country or even within the province. Earlier on, I was talking about contextualizing to either a district, a province, a community, and in this case, maybe this camps would be an area that needs to be targeted with special or targeted interventions. Thank you.
Thank you, Susan. We now have another question specifically for Kai, asked by Kai. Jeffra Kulani. It's on stigma. Stigma surrounding a disease often originates not just at the local or community level, but also among professionals and those within global institutions. Stigma can manifest itself in language, narratives, images used to represent diseases like mpox. What community protection measures are being implemented at these higher levels to address and to mitigate this? Over to Kai, it's addressed specifically to Kai, but I would also then like to request other colleagues, perhaps Umbretta and Susan, if they have any further views, because I know all of you have worked on stigma. So over to Kai.
Yeah, thank you very much, Supriya. And I think it's a very, very important topic. Again, can really create a significant barrier to public health response, and in particular is an issue in mpox, of course. We have developed guidance on addressing stigma and discrimination that is currently being updated. Of course, I think, and I think we all have to be very mindful of the language we are using. It's very important to highlight the risk of certain groups, for example, to provide them with accurate information, but at the same time avoid, and be really aware of the impact of that our language can have. And there are different considerations for different actors in the guidance. It really highlights and gives examples of non-stigmatizing terminology. It includes how this can be incorporated in our risk communication, community engagement plans, and also how it can be, what is important when talking, for example, with the health workforce around it, which is very important, but also the general population, how we can work with media on this topic, and then how do we engage with communities. What, of course, there are many aspects to it. The main important one is that we stick to accurate language. We spread the facts. We kind of convey the diverse people that can contract mpox. We engage with people with lived experience of mpox, and we also engage with community leaders, with social influencers, with trusted voices on the topic who can really speak and are really the most effective transmitters of our messages. I think these are some aspects, and I don't know if Meg would like to come in as well, because I know it's a very important topic that she's working on as well. But over to you.
Kai, I think you covered it really well, but there are lots, and certainly there is a public health advice on how to avoid stigma and discrimination in the facilities, in the workforce, and also self-stigma that can occur around mpox that may limit people seeking care. And that guidance is really quite important, especially when one thinks about some of the stigma that can occur with if there is sexual networks involved. If it's MSM and or sex workers, there may be challenges with coming forward for fear of what might happen in the community. So language matters, but as Ruben brought forward, not speaking about people whose certain behaviors may put them at risk is also dangerous. So it's important to be very frank, open, use the language that is acceptable to the community so that all people, no matter who they are, have the right information, and then also feel empowered to get the kind of care, ask for testing, ask for standardized treatments, and when available, line up for immunizations when they come to the place where they'll be. So very important, and I think we'll be looking for feedback from the new settings with Clade 1B, whether it's in families or family units or children, and how to address some of that stigma going forward. I think we'll have to be developing more tools with local partners and those people who are working in those countries. Thank you.
Thanks very much, Meg, for that perspective. We've also, Meg's team has worked on stigma, and last year's mpox also we had spoken about it. We're just putting on the chat the link to that webinar and the updates we have there, which I think some of it is still valid. We don't have a lot of time, we just have 2 more minutes, but then so very quickly to Umbretta and Meg, what behaviors can people adopt to avert mpox in the communities? Maybe Umbretta first and then Meg.
Sure, thanks so much for the question. So we said, and also Maria said at the very beginning, this is spread through close contact. So it's really be mindful of the signs and symptoms of the people around you. This is mindful means make sure that you're not in touch with those fluids and those parts that could cause the infection. We see many children getting infected. We know that there is more than we need to understand around that, but of course, taking care of people who might be sick is make you at risk. So making sure that you take all the precaution, have your hygiene practices. We've learned a lot also around hand washing during COVID. That's something that we need to continue to do as a practice, of course, that is healthy for many diseases, and this is one of those. So I think this is what I can say in the short time we have. Over to you, Supriya and Meg.
Thank you. I could just add. Oh, sorry, Supriya. I could just add, really go back to the basics of, the things we discussed all along with communicable diseases and, good washing hands. Mpox is spread through person-to-person contact and close contact. And so therefore, if somebody has open lesions or is suffering from mpox at the time, there can be isolation if it's at home, avoiding touching, cleaning all the linens, etc. There are just some basics that are on our website about hand hygiene, home care, and what to do in the home, as well as watching your own behavior and ensuring that you're not stigmatizing others. If somebody is engaging in sexual activity, reducing the number of partners, knowing one's partners, and avoiding sexual activity if you or somebody else has lesions or is worried about mpox. Now, mpox can come forward and look like many other things. So I think being aware of what are the other infections that may look like mpox is also really important, especially in kids. This could be things like measles or other eruptive infections. And for adults, certainly sexually transmitted diseases that can have lesions in the genital areas. So just being completely aware, reading up on the materials, looking at social media, knowing oneself, not stigmatizing others, and taking good hygienic care, and reducing risk and reducing contact with those who might be exhibiting mpox lesions. Thanks. Back to you, Supriya.
Thank you very much, Meg. And with that, I think I'd like to invite Dr. Nedret Emiroglu to provide the closing remarks. Thank you very much for your questions. I just want to say that there have been a number of questions. I think we have almost 100 questions. Most of them are on a range of issues around mpox. And I encourage you to go to the mpox website, and there are fact sheets and Q&As there that may answer some of your questions. And we will also have a series which will deal with focusing on different areas of mpox. And so please do join us, and those will answer your questions. But for today, I'd like to invite Dr. Nedret Emiroglu, Director for Country Readiness and Resilience, to provide the closing remarks. Nedret,
thanks a lot.
The floor is yours.
Thanks a lot, Priya. Let me start by thanking all who joined us today. I see a huge interest. A special thanks to panelists. I think hearing from different agencies and not from only WHO, and particularly from the field, is impressive. Special thanks to Susan and Ruben, actually. What you have demonstrated and showed has been really extremely useful in understanding. As Priya mentioned, I don't want to take your time anymore on the importance of community protection, but this is only one of the response elements or functional areas, or how we call as subsystems within the health emergency architecture. So we will definitely continue these webinars. We will give you more information on the safe and scalable care, which includes clinical management, infection prevention and control and WASH, where there were a lot of questions, as well as public health and social measures, medical countermeasures, surveillance, laboratory, and so on. But we want to start with the community protection because of the unique nature of mpox, as well as the context it's being seen. As was repeated by Susan, without the communities, we cannot do anything in responding to an emergency. And particularly if we're talking about a complex, security-related, challenging environment with highly fragile, vulnerable key populations, with the stigma discrimination, it requires even more for us to be with the communities, to work with the communities. And I like again, Susan, I will quote you, that community protection or community readiness and resilience for health emergencies is not only risk communication and community engagement. It is working with the communities, taking the whole of society, whole of government approach, finding local solutions, working with all the stakeholders, the leaders, community networks, and civil society, and so on. I can talk too long, but it is such a passionate area, and all the other elements, the functions, the surveillance, the laboratory, the medical care, other social economic impacts, they all come connected within the community. So please follow up the future EPI-WIN webinars. I think, as I said, we will deal with the different areas of interest, but I think starting with community protection was the most critical element. And I see like this is everybody's responsibility. Each and every one of us could make a change within the community. And then I would like to also have a special thanks to my director colleagues, Meg, for leading the area and contributing, and Maria as well as the leading the instant management work within response to mpox. And thank you so much to the team for a good preparation. So we will try to respond to many of your questions. Goodbye and have a good day.
Thank you
Bye.
very much, Nedret, and thanks to
Bye-bye.
everyone. Thank you to all the participants, and we hope to see you in our next EPI-WIN webinar, which will be on the 18th of September. And do share with us what you do with this information. As I mentioned earlier, we do not just give certificates, we only send those to those who let us know how they use the information in their lives. So we look forward to hearing from you and seeing you again. Thank you once again for being a wonderful audience and participating in this, and hope to see you soon as part of the EPI-WIN family. Bye.